In terms of pharmacological therapies for IBS, you can see here that they're largely predicated upon the patient's predominant or most bothersome symptom. So whether it's bloating, abdominal pain, diarrhea, or constipation, you can see that there's some overlap in regards to the therapies that are selected on the basis of these different symptoms, but that for the most part, they're pretty distinct. That depending upon what symptoms a patient has, you're going to choose different therapies. And I think one take-home message is that I take away from a slide like this is the fact that the phenotype is quite varied. But I think from a pragmatic standpoint, a big issue is that anytime there's this many therapies on a slide that discusses one disorder, it tells you that none of the therapies work very well. And I think, again, that really goes back to that issue that I mentioned a moment ago in regards to the fact that we're empirically choosing therapies based on symptoms, not based upon pathophysiology that underlies the symptoms. And we're going to be in this mode for a while longer, is the bottom line, I think. So I think one has to expect that an effective therapy for IBS is likely to be no more effective than 10 to 15% over placebo, because given our construct, I just don't think that it's going to be possible to do better than that. Now, let's go through some of the therapies for these different phenotypes. So first, we're going to talk about constipation-predominant IBS, and you can see here is the recommendations from the American College of Gastroenterologists IBS Task Force. It was published a couple of years ago now. And the therapies that they evaluated in their analysis were fiber, laxatives, lubiprostone, antidepressants, and then at that point, tegaserod was still commercially available. So let's go through the evidence for these different therapies. So first, we'll talk about fiber. This is data from a meta-analysis that was published by Alex Ford and Paul Moietti in the British Medical Journal several years ago now. They included 12 randomized controlled trials, almost 600 patients. 2 of the studies recruited only IBS-C patients and realized that 5 of the 12 studies were of quite poor overall methodological quality. So the flip side is that 7 of 12 were at least of moderate methodologic quality. Now, when you look at this analysis overall, if you look at the potential benefits of fiber versus placebo for IBS overall, recognizing this is all subgroups of IBS, actually there's no statistically significant benefit for fiber over placebo. You can see that the 95% confidence interval actually reaches 1. I think the p-value was just over 0.05. So it was just short of statistically significantly different, but it was not statistically significantly different. And I think one would, even if you're going to argue about the statistics, I think you'd be hard-pressed to suggest that a 5% therapeutic gain over placebo is clinically meaningful. So does that mean fiber has no value in IBS? Probably not, because another way to think about this is to look at soluble versus insoluble fiber. So the most commonly utilized fiber supplements in the United States are probably insoluble fiber in the form of Bran. On the other hand, one of the most commonly recommended fiber supplements by physicians are soluble fibers, things like methylcellulose, calcium polycarbophyll, or psyllium, or ispagula husk, of which those two are the same thing. Ispagula husk and psyllium are actually the same thing. And what you see is different results when you break down the data on the basis of insoluble versus soluble fiber. Actually, for insoluble fiber, that is Bran, there's no statistically significant benefit whatsoever as a treatment for IBS. On the other hand, for soluble fiber, in this case ispagula husk, with 6 studies, there was a statistically significant benefit. And so the take-home message for me out of this analysis is, if you're an evidence-based person and you're recommending fiber, you should be recommending soluble fiber, not insoluble fiber. And actually the same holds when you look at the constipation data as well. Now, this suggestion was actually, I think, enhanced to some extent by a large randomized controlled trial that was published in BMJ about a year after that meta-analysis was published. This was a study by Bajork and colleagues that it was a comparative effectiveness trial that looked at psyllium versus Bran versus placebo in patients with IBS. And they actually found in this analysis that psyllium did better than placebo, just like in the meta-analysis I showed you a moment ago. If you looked at Bran versus placebo, there was no statistically significant benefit at the primary endpoint, which was 1 month. And then finally, if you did the comparative effectiveness analysis between psyllium and Bran, psyllium did better than Bran at 1 month. Now, in fairness, you have to say that the benefits seem to wane by 3 months, But at least early on, there appeared to be greater benefit with the soluble than the insoluble fiber. One of the problems with looking at the 3-month analysis is they had a huge number of patients drop out of the study, so it's harder to know what that data means. But at their primary endpoint of 1 month, Psyllium did better than Bran. All right, how about osmotic laxatives? Most common osmotic laxative used in IBS is PEG, polyethylene glycol. Turns out there's only one study evaluating PEG in patients with IBS. This is a randomized controlled trial in 27 adolescents with IBS-C. And I think this study is really interesting because it's a 1-month study, so it's a very short-term study, which may introduce some bias. But at 1 month, what they found was that PEG actually led to statistically significant improvements in terms of stool frequency and stool form. So for constipation, it definitely made it better. But look at the right side of the panel in terms of what it did for abdominal pain, which is nothing. It didn't do anything for abdominal pain. So interestingly, it benefited the constipation symptoms, but did not help with abdominal pain in these patients with IBS-C. Now, one might argue that maybe 1 month wasn't long enough. If you had randomized and treated for a longer period of time, maybe you would have seen pain benefits. But unfortunately, this is the only data we have at the current time. All right, how about chloride channel activators? Well, there are 2 big classes of drugs here, which I'll try to briefly move through. One is a group that directly affects CLC2 channels and leads to net chloride secretion. Net chloride secretion by any mechanism will lead to paracellular movement of sodium in water. The net result is benefits in terms of stool consistency, increasing biomass, and stimulating secondary peristalsis. The other category are drugs that actually activate GCC receptors on the apical surface of the enterocyte, leading to an increase in intracellular production of cyclic GMP, which then activates CFTR, the cystic fibrosis transmembrane regulator, which also leads to net chloride secretion. Now, for lubiprostone, there's data from 2 large, methodologically rigorous phase 3 randomized controlled trials published by Doug, actually, a couple of years ago, that showed benefits for lubiprostone using a very rigorous multi-tiered responder definition, which is why these response rates, part of the reason why these response rates are so low, compared to placebo. In addition, there's been a study that was just published within the last couple of months on the long-term efficacy as well as safety of lubiprostone, a 36-month extension trial, which again showed sustained clinical benefits and a safety profile that was almost identical to the first 12 weeks of randomization over 36 further weeks of treatment with lubiprostone. The main side effects related to lubiprostone are nausea is really the main thing. And nausea is most relevant of an issue with the higher dose that's FDA approved for chronic constipation. Actually, the IBS dose of 8 mics BID really causes little in the way of nausea. In fact, you can see that that nausea really should be thought of as a linearly dose-dependent side effect associated with lubiprostone. In either case, the good news is that most of the nausea that occurs with lubiprostone is mild and transient, but it is an issue that you need to be aware of and talk to patients about if you start this medication. Also realize that the elderly and men are also less apt to report nausea than younger women with these conditions. Linaclotide is a new kid on the block. This is actually a guanylate cyclase C agonist that works through CFTR to increase chloride secretion into the intestinal lumen. This drug has been evaluated both in chronic constipation as well as IBS-C. The data from the 2 phase 3 IBS-C trials were presented at Digestive Diseases Week last year. This is an analysis from the primary responder definition, which is the FDA composite endpoint, which required a greater than 30% reduction in abdominal pain and an increase of greater than 1 complete spontaneous bowel movement from baseline per week. And what you can see is that about 34% responded with linaclotide versus around 14% with placebo. The main side effect with this drug, not surprisingly, is diarrhea. This is a constipation drug after all. About 18% developed diarrhea versus around 2% in the placebo group. Now moving on to diarrhea-predominant IBS. Drugs like loperamide are available. I'm not going to talk about that to any significant degree. I will say this, is that loperamide works really well for diarrhea. So it tends to help with stool frequency as well as stool consistency. But in the studies that are available, and there's only really 2 or 3 small randomized controlled trials, there has not been much in the way of benefit for global symptoms or abdominal pain. Antispasmodics we'll talk about, and antibiotics we'll leave antidepressants to one of the speakers coming up. So I wanted to show you this. First of all, just realize that in the real world, by far and away, the most commonly utilized or prescribed medications for IBS are antispasmodics. Actually, I found this to be quite striking, this analysis from the Northern California Kaiser database that Yuri Ladabaum just published in CGH. And orders of magnitude more likely to get an antispasmodic than any other prescription medication for patients with IBS. You can see 57% of the IBS patients were at some time or another within their time frame prescribed an antispasmodic. Now compare that to a prescription antidiarrheal at 15%, a prescription laxative at 3%, which I think I was really struck by this finding. And then if you look at things like Alosetron, virtually almost never prescribed, 0.1%. All right, so let's go through the data. So everybody seems to use and like antispasmodics. How well do they work? Well, there's data from 22 randomized controlled trials that was published by Alex Ford and Paul Moetti, again in BMJ. Most of the data was for drugs that we don't have in the U.S. That's the first thing to say. So drugs like odolonium, trimabutene, simatropium, pinivarium, the largest quantity of high-quality data on antispasmodics was for those drugs, and unfortunately, none of those drugs are available in the United States. We do have hyoscine in the United States, but it's not FDA approved for the treatment of IBS. The drug we have for IBS is hyoscyamine, which is very similar to hyoscine. Now, their analysis showed that symptoms persisted in 39% of patients treated with antispasmodics versus 56% of patients randomized to placebo. So there was a reduction in the likelihood of remaining symptomatic by around 32% with the antispasmodics. Unfortunately, there was a lot of heterogeneity, and of course, you'd expect that with that many different kinds of drugs from many different countries using many different populations. I think the other thing to say is that these drugs appear to be most effective for abdominal pain, and I would actually argue that they're most effective for postprandial abdominal pain. I think they are actually quite effective for patients that have postprandial abdominal pain because the gastroclonic response is partially cholinergically mediated. So there's a pathophysiological basis upon which to build an argument that these drugs would be beneficial for that group. But for patients with chronic pain, that is pain every day most of the time, I think these drugs are completely ineffective. And in fact, I can't even understand a pathophysiological reason why you would expect them to be effective for that type of pain. How about rifaximin? Well, rifaximin is a non-absorbed oral antibiotic. It's a derivative of rifamycin, which is an anti-TB drug. And rifaximin has been evaluated now in 5 randomized controlled trials as a potential treatment for patients with IBS. This is actually data from a meta-analysis that we published just a couple months ago in the American Journal, summarizing the data from those 5 randomized placebo-controlled trials. First, if you look at rifaximin for global improvement of IBS symptoms, what you see is first of all, is that for all the studies, there were statistically significant benefits favoring rifaximin versus placebo. When you pull the data together, the response rate for rifaximin was 43%, for placebo was 34%, yielding a therapeutic gain of around 9%, and a number needed to treat of around 11. How about for bloating? Well, bloating looked very, very similarly. 4 trials here using that as an endpoint. All trials showing benefits with rifaximin versus placebo, therapeutic gain around 9 to 10%, number needed to treat about 10 to 11. Now, at this point, I think that the discussion about whether there is a subgroup of patients with IBS that benefits from antibiotic therapy, at least rifaximin therapy, I think that discussion's over with. We actually have more data on this topic than we do for most of the other therapies that are routinely used in clinical practice. But that's by no means does that mean that we're done with this discussion. There are a tremendous number of questions that remain. For example, the reasons for symptom improvement aren't clear. I mean, are we treating SIBO or are we altering colonic flora? We really don't know. If it's SIBO, how do we diagnose the patients that are most likely to benefit from this strategy? I already told you that breath tests aren't very good. The optimal antibiotic therapy is not clear. So the data we have right now is for rifaximin, but that doesn't mean that there aren't other antibiotic therapies that might also be a benefit. The benefits appear to be transient, and this is probably the main reason why the complete response letter that went back to the manufacturer of Rifaximin did not grant FDA approval for this drug for IBS is because patients oftentimes will experience recurrent symptoms after some set time point, and how to manage patients that come back with recurrent symptoms is an open question. In fact, that's the subject of a large randomized prospective study that's going on in the United States at the current time. And then the potential consequences of repeated widespread antibiotic use is obviously a very important question in this day of epidemic C. difficile infection. Last thing I'll just mention is 5-HT3 receptor antagonists. This is probably the best studied and most underutilized category of drugs available for diarrhea-predominant IBS. So very large data set with very high quality data. 11 randomized controlled trials in this meta-analysis that Alex Ford, Paul Moietti, myself, and others published a couple of years ago now, showing robust benefits for a 5-HT3 receptor antagonist versus placebo. You can see there the therapeutic gain around 15%, the number needed to treat 7 with this particular set of compounds. There's even data from a 1-year placebo, a randomized placebo-controlled trial. This is one of the only drugs for which we actually have a 1-year randomized placebo-controlled trial showing sustained benefits for Alosetron versus placebo. And so what's the rub? Why isn't everybody on Alosetron? Well, the main reason is related to safety. So yes, this drug does work, clearly works for a subset of patients with diarrhea-predominant IBS. The issue is that unfortunately it can work too well for some patients. That is, some patients will actually develop constipation, and that constipation can be quite severe. And then a very small proportion of patients will go on to develop ischemic colitis. And for this reason, this drug is only available through a restricted access program, and I think it's only available in the United States. It's really not available in Europe or most parts of Asia at the current time. So this drug is really only indicated for women with severe diarrhea-predominant IBS who have failed to respond to traditional medical therapies. And so if you think about that, right out of the chute, this is only intended for a very small proportion of IBS sufferers. So to summarize, there's mounting evidence to support selected lifestyle and dietary modifications for IBS. I didn't actually go over that because to save time, I skipped those slides. For diarrhea-predominant IBS, antibiotics and probiotics are interesting new options, I think. And there are some questions that remain, but I think there is a potential role for both of these classes of compounds. Alosetron should be considered in patients with severe diarrhea-predominant IBS for IBS-C. Fiber and laxatives help with constipation symptoms, but may not benefit pain or global IBS symptoms. I don't think we have convincing data in that regard at the current time. Lubiprostone is the only drug that's FDA approved right now, prescription drug for constipation-predominant IBS. Linaclotide is on the launching pad. Actually, we'll be receiving word from FDA on this particular compound within the next several months. So with that, again, I'll stop and thank you for your attention.